A 28-year-old black man presents with 6 weeks of progressive ankle and periorbital swelling, new frothy urine, orthopnea requiring 2 pillows, and an 11-pound weight gain. He denies gross hematuria, recent infections, non-prescription nonsteroidal anti-inflammatory drug use, or anabolic supplements. Past medical history includes mild intermittent asthma and seasonal allergic rhinitis. Family history: father with type 2 diabetes, no kidney disease. He does not smoke, drinks alcohol socially, works in information technology, and reports no recent travel or sick contacts. No known drug allergies. Clinic vital signs: blood pressure 148 over 92 millimeters of mercury, heart rate 96 per minute, respiratory rate 18 per minute, temperature 36.8 degrees Celsius, oxygen saturation 93% on room air. Physical examination: periorbital edema, jugular venous distension to the angle of the mandible at 45 degrees, bibasilar crackles, a soft third heart sound, tense bilateral pitting edema to the knees, a small non-infected flexural eczema patch on the right antecubital fossa, no rashes, purpura, oral ulcers, synovitis, or focal neurologic deficits. Initial laboratory evaluation: serum creatinine 2.0 milligrams per deciliter, prior baseline 0.9 milligrams per deciliter, albumin 1.9 grams per deciliter, total cholesterol 330 milligrams per deciliter, low-density lipoprotein 210 milligrams per deciliter, triglycerides 320 milligrams per deciliter, hemoglobin A1C 5.6%. Urinalysis: 4 plus protein, no hematuria. Quantification: 24-hour urinary protein 10.8 grams, spot urine protein to creatinine ratio 9.2 grams per gram on a separate day. Urine microscopy: bland sediment without red blood cell casts. Complement C3 and C4 within reference ranges. Hepatitis B surface antigen and core antibody, hepatitis C antibody with reflex ribonucleic acid, and 4th-generation human immunodeficiency virus testing with negative human immunodeficiency virus ribonucleic acid are negative. Antinuclear antibody negative. Serum antiphospholipase A2 receptor immunoglobulin G undetectable. Serum and urine protein electrophoreses, no monoclonal proteins. Parvovirus B19 polymerase chain reaction negative. Thyroid stimulating hormone 1.1 milli-international units per liter. Renal ultrasound: normal-sized echogenic kidneys without hydronephrosis. Transthoracic echocardiography: normal chamber sizes and left ventricular ejection fraction, 62% without diastolic dysfunction. APOL1 genotyping: no G1 or G2 high-risk allele. Native kidney biopsy after stabilization: focal segmental glomerulosclerosis, Columbia classification not otherwise specified variant, segmental sclerosis in 6 of 20 glomeruli, negative immunofluorescence for immune complexes. Electron microscopy shows diffuse podocyte foot process effacement. High-dose oral prednisone for 4 months, followed by tacrolimus for 3 months, does not reduce proteinuria. Kidney function worsens, and he progresses to kidney failure. He undergoes a living donor kidney transplant at a United States academic transplant center. Immediate postoperative course includes tacrolimus, mycophenolate mofetil, and daily prednisone, with perioperative antimicrobial prophylaxis. Intravenous loop diuretics and supplemental oxygen are continued. A tunneled apheresis catheter is in place. Current inpatient medications also include atorvastatin, pantoprazole, trimethoprim sulfamethoxazole prophylaxis, albuterol inhaler as needed, cholecalciferol, and melatonin at bedtime. He reports occasional cetirizine use for allergies and continues to avoid nonsteroidal anti-inflammatory drugs. At 60 hours after graft reperfusion, urine becomes markedly frothy. Spot urine protein to creatinine ratio is 8.7 grams per gram. Allograft biopsy on postoperative day 3 shows widespread podocyte foot process effacement without immune deposits on immunofluorescence or electron-dense deposits, negative complement component 4D staining, and no endocapillary hypercellularity or thrombotic microangiopathy. Daily therapeutic plasma exchange sessions are initiated in the hospital apheresis suite. Proteinuria decreases over subsequent treatments. Which mechanism best explains this very early recurrence of nephrotic range proteinuria in the renal allograft? Option A: inherited complement factor H deficiency, causing uncontrolled alternative pathway activation with low complement component 3 and glomerular endothelial injury manifested by thrombotic microangiopathy, capillary wall double contour formation, and platelet-rich thrombi on biopsy. Option B, mesangial deposition of galactose-deficient immunoglobulin A1 containing immune complexes with alternative pathway complement engagement, yielding dominant or codominant mesangial immunoglobulin A with complement component 3 on immunofluorescence and mesangial hypercellularity with expansion on light microscopy. Option C, antiglomerular basement membrane autoantibodies directed against the alpha 3 type 4 collagen NC1 domain with complement fixation, producing linear immunoglobulin G along the glomerular basement membrane and necrotizing crescentic glomerulonephritis in the allograft. Option D, a circulating permeability factor, exemplified by soluble urokinase type plasminogen activator receptor, binding podocyte alpha V beta 3 integrin to activate Rho family guanosine triphosphatases and reorganize the actin cytoskeleton, producing diffuse foot process effacement that improves as the factor is removed by therapeutic plasma exchange performed in the inpatient apheresis suite. The correct answer is option D, a circulating permeability factor, exemplified by soluble urokinase type plasminogen activator receptor, SUPAR, binding podocyte alpha V beta 3 integrin to activate Rho family guanosine triphosphatases and reorganize the actin cytoskeleton, producing diffuse foot process effacement that improves as the factor is removed by therapeutic plasma exchange performed in the inpatient apheresis suite. Massive proteinuria recurring 60 hours after reperfusion with an allograft biopsy that shows isolated diffuse podocyte foot process effacement and no immune deposits is the textbook pattern of recurrent primary focal segmental glomerulosclerosis mediated by a circulating permeability factor. Kidney disease, Improving Global Outcomes 2021. Glomerular diseases emphasizes that the strongest clinical evidence for a circulating factor is immediate or very early post-transplant nephrotic range proteinuria with electron microscopic effacement and improvement on plasma exchange. Mechanistic work has implicated soluble urokinase plasminogen activator receptor as an exemplar factor. Soluble urokinase plasminogen activator receptor can engage podocyte alpha V beta 3 integrin, triggering Rho family guanosine triphosphatase dependent actin cytoskeletal remodeling that increases podocyte motility and disrupts slit diaphragm integrity, leading to albumin leak. Therapeutic plasma exchange performed in an inpatient apheresis suite lowers the burden of circulating factor S, allowing partial reversal of podocyte cytoskeletal injury and a rapid fall in protein in urine. The three alternatives describe pathobiology that conflicts with this patient's biopsy pattern and time course. Mesangial immunoglobulin A immune complex disease produces dominant or codominant immunoglobulin A with complement component 3 and mesangial hypercellularity, not an immune complex negative biopsy with isolated podocyte effacement within days. Antiglomerular basement membrane disease causes linear glomerular basement membrane immunoglobulin G with necrotizing crescents and rapidly progressive nephritic presentations. None of these features are present. Alternative pathway dysregulation from inherited complement factor H deficiency produces complement-mediated thrombotic microangiopathy with capillary wall double contours and low complement component 3. Complements are normal here, and the allograft biopsy shows no thrombotic microangiopathy. Together, the immediate nephrotic relapse, ultrastructural podocyte injury, and plasma exchange responsiveness point to a circulating factor that activates podocyte alpha V beta 3 integrin signaling.